In this unit we'll be looking at some of the more common causes of kidney disease, also known as disorders of renal function. The material for this unit comes out of Copstead, chapters 27 and 28. The numbers are on this slide, page numbers from 27 and all of chapter 28. The renal system is a very important system in nursing and health and medicine. Because there's more than 10% of the people in the United States aged 20 years or older, or that would be more than 20 million people, have chronic kidney disease. So it's an extremely common organ that has problems and disease issues. Before we start talking about diseases, let's kind of back up and look at the anatomy and physiology. And I would encourage you to kind of review the physiology of the kidney in depth if you've got the time and inclination to do that. Your textbook has a really nice review in chapters 26, so if you would take a few minutes to peruse that, I think it would be of great benefit. So let's look at the anatomy. Anatomy is vital in understanding kidney function and kidney disease. And so really, we'll maybe work our way from the outside of the kidney to the inside of the kidney in an anatomic standpoint. And one thing I don't have on the list, I should put it on the list, is the renal capsule. So this organ is actually encapsulated with connective tissue, and that's important when we deal with swelling or fluid buildup and pressure buildup. This organ has a limited capacity to swell. It will, but it's got that capsule kind of holding it into anatomic position. Moving a little bit deeper, we have the renal cortex, and this is where we have our blood filtering process occurring in the glomerulus. And the renal cortex then drains down. If we look at number 2 in the figure on the right-hand side, into the renal pyramid. And so inside of the cortex, or deep to the cortex, we have these little segmented areas of renal tubules actually that make up the renal pyramid, and between each renal pyramid we have a renal column. So there's tissue between each one separating, actually it's cortical tissue in between each one of those renal pyramids. The renal pyramids then drain down, if you look at number 4, into the renal calyx. So at this point we really have a urine, and that renal calyx kind of drains into what we call the renal pelvis, which is number 7 on the kidney on the right-hand side. And that renal pelvis then drains into the ureter, and it makes its way down into the bladder. Deep to the cortex, that area that we had the pyramids and the columns, we call that the renal medulla. So the outside is the capsule, a little deeper is the renal cortex where we filter. The renal medulla is made up of columns and pyramids, and that's primarily tubular tissue from the nephron. Then it drains into the renal calyx, into the pelvis, and finally out into the ureter. Getting down into the microscopic anatomy of the kidney, the functional unit, the actual functional unit of the kidney is the nephron. And the nephron is made up of 2 different types of elements. One is our vascular element, or the renal glomerulus, where plasma is actually filtered out into the tubular element. The tubular element is made up of Bowman's capsule, which surrounds the glomerulus, which is where the filtrate coming from the blood actually enters first. It leaves the Bowman's capsule and flows into the proximal convoluted tubule. And from there, the proximal convoluted tubule kind of dives deep into the renal medulla, into what we call the loop of Henle. And there's a descending loop of Henle and an ascending limb of the loop of Henle. If we notice on the ascending limb, we have both a thick and a thin aspect to that. And again, that's going to be important because we've got different permeabilities as we go through that loop of Henle. Distal to the loop of Henle, as we continue our flow downstream, we get to the distal convoluted tubule. And finally, these distal convoluted tubules, multiple distal convoluted tubules, actually drain into the collecting duct, which is where the kidney finally controls the osmolarity or concentration of the urine. So in normal physiology, we actually have 3 processes that occur in the nephron. The first is glomerular filtration, and the important thing to remember with this is that most solutes in plasma actually are filtered. They're freely filtered, so the electrolytes, simple amino acids typically, so small molecules, sugars, right? So glucose would actually be filtered as well. So if it's small enough to make it through the renal corpuscle or into the glomerulus, it is going to be filtered. That's a very important thing to remember. Things that aren't filtered are large molecules, which are typically proteins. Okay, so our blood protein, albumin being the most concentrated of all the proteins, as well as antibodies, clotting factors, those kind of things will stay in the blood plasma. They will not be filtered, so they are too large. So again, solutes are freely filtered, proteins are typically not filtered. The next phase we have is tubular reabsorption, and most of this occurs in the proximal convoluted tubule. Okay, and since virtually all solutes found in blood plasma are being freely filtered, we want to get some of those back. So, for example, our amino acids, our sugar, our glucose, we don't want to lose that. We want to get that back. So we will reabsorb that. And again, most of that, about 99% of it, is going to be reabsorbed back into the bloodstream. The third function of the renal, the nephron, is secretion. So now we're taking things from the blood and actively putting them into the filtrate, into the lumen of the nephron. And so that's very important with certain waste products, very important in drug therapy. So for example, penicillin is actively secreted, so therefore concentrations and clearance, which we'll talk about in a little bit, of certain drugs can be much higher than they are in plasma. So if we look at that process that occurs all the way till essentially we get into the collecting duct, once it leaves the collecting duct and it enters into the renal calyx, it is now done. So it is at that point we really consider it urine. It's no longer a filtrate, and we can't filter, we can't reabsorb, we can't secrete it anymore at that point. So in a nutshell, excretion. Okay, so at that point, once we make urine, it's considered excreted. So excretion of any solute equals the glomerular filtration of that solute plus the secretion of that solute if that occurs, minus the reabsorption of that solute if that occurs. So looking at the first process, glomerular filtration, here we have a diagram of our renal corpuscle, the glomerulus, along with Bowman's capsule on the outside. And we've got our vascular elements coming into that capsule. So we have our afferent arteriole, which is coming in from the top of that diagram, and the arrow goes towards the corpuscle. Blood comes in there, is filtered out in the renal corpuscle and the glomerulus, and then it exits out the efferent arteriole. Now, the important thing to remember is those arterioles are arterioles, and they can dilate and they can constrict. And so I really like this diagram because we actually have nerves connected to the afferent arteriole, showing our autonomic nervous system how it can actually control filtration rates depending on whether we dilate that afferent arteriole or constrict that afferent arteriole, which would change the pressure downstream, causing more or less filtrate to occur. So let's look at the forces that drive this. They're the exact same forces that drove it when we talked about the vascular system. First, we have our glomerular hydrostatic pressure. So that is our blood pressure entering into the renal corpuscle. That is going to drive fluid out. Okay? And so on average, in a normal, healthy individual, we'll have a hydrostatic pressure of about 55 millimeters of mercury. Once that filtrate starts moving out, it's got limited space in that capsule. And so that capsule acts essentially like a water balloon. As it fills up, pressure builds up outside there, and it starts pushing back on that filtrate. And so the force pushing the filtrate back into the renal corpuscle is called capsular hydrostatic pressure, and that's about 15 millimeters of mercury on average in a normal, healthy individual. And so at this point, with our glomerular hydrostatic pressure pushing out at 55 millimeters of mercury, our capsular hydrostatic pressure pushing back in at 15 millimeters of mercury, if I do my math right, we have a net filtrate pressure going out of about 40 millimeters of mercury at this point. But remember, we have one last force that we deal with, and that's our blood colloid osmotic pressure, remember, also known as oncotic pressure, and that's our plasma proteins that are found inside of our vasculature, and those are actually pulling fluid back at a force of about 30 millimeters of mercury. And so the forces pulling fluid back would be 15 plus 30, right? Our capsular plus our blood osmotic pressure coming back in, and the force pushing fluid out is about 55 millimeters of mercury. That's our hydrostatic pressure. And so if we do the math, if we take 55 minus 15 minus 30, our net filtration pressure is a positive 10 millimeters of mercury, which means that there's a net pressure pushing plasma out of the out of the corpuscle into the capsular space, and less. So we have a net outflow of plasma in the renal corpuscle, in the glomerulus. So now that we've filtered our plasma and formed our filtrate, we'll kind of look at what happens, how we modify it as we go along the nephron, as a quick review here. And so if we remember, we actually filter approximately 180 liters per day. So if you do the math, liters approximately a quart, a little bit more. So 4 quarts per gallon. You're looking at 180 divided by 4. It's roughly about 45 gallons of filtrate that we do per day. And this is isosmolar with plasma, so it's about 300 milliosmolar, because remember, our blood plasma is approximately 300 milliosmolar, depending on your hydration status, of course. But so at this point, we've filtered out 45 gallons. If we did nothing else, that would mean you'd have to drink 40 to 50 gallons of water a day to replace all of that filtrate. Well, fortunately, we don't have to do that, and so let's kind of go through the process that occurs from there on. So the filtrate now enters into the proximal convoluted tubule. The primary function of the proximal convoluted tubule is reabsorption. In fact, about 70% of that filtrate is reabsorbed, and so only about 54 liters per day make it to the end. And so remember, we are also at this point reabsorbing our sugars, our amino acids, and all the things that we need to keep in our plasma for metabolism, metabolic purposes. So, all right. So by the time we get to the end of the proximal convoluted tubule, we've only got 54 liters per day, and we're still isosmolar. We're at 300 milliosmolar at this point. Now things are going to start changing. So we drop down into our descending loop of Henle. And if you remember from physiology, in the descending loop of Henle, it's that area is primarily permeable to water, and not permeable to solute. Okay, so as we go down that descending loop, and again remembering from physiology that the osmolarity of that loop, actually the interstitial fluid around that loop, increases the further down into the medulla we go. And so at the start, we're roughly going to be at 300 milliosmolar. As we descend down to that hairpin turn, we're at about 1200 milliosmolar. Okay, so at this point, we've removed a lot of water. We've removed very little solute. As we go down that hairpin turn, now we start coming up, and we get to that thick ascending loop. Now we have the opposite happening, where it's impermeable to water, and we have our sodium-potassium, our sodium chloride pump, excuse me. So we're removing sodium chloride at this point, and so we start pumping out massive quantities of sodium and chloride, and we get to the top of the ascending loop of Henle, or the end of the loop of Henle, essentially. We only have 18 liters at this point now per day, and now we are actually at 100 milliosmolar. So we pulled enough solute out there that now we are actually hypoosmolar to our plasma. Okay, so we've changed quite a bit. We've lost a lot of volume, and we've also lost the concentration of solutes in that filtrate. So now we go down to the distal tubule. We have secretion and reabsorption going on there as well. And then we enter the collecting duct, and this is actually where we change the osmolarity of the urine. I don't have on this slide, I guess, the osmolarity once we get to the end of the distal convoluted tubule, but at there we actually get back to about that 300 milliosmolar point. And now we drop down into our collecting duct, which is going to be under the influence of antidiuretic hormone. So if we have a lot of antidiuretic hormone, it means we're going to reabsorb water, and the osmolarity of our urine will go up to a maximum of about 1200 milliosmolar. If we are not under the influence of a lot of antidiuretic hormone, then we actually want to get rid of water, and so we can have dilute urine, right around 50 osmolar. So again, depending on our hydration status and how much activity we have on antidiuretic hormone, we will change that concentration. So going back to how we measure this, if you send a urine sample into the lab, you will get back a concentration in milliosmolar. So you will actually see if it's either 50 milliosmolar, 300 milliosmolar, 1200 milliosmolar, which would be very, very concentrated, or somewhere in between. It's easy to do this in your clinic. You don't have to send it to the lab. Using a refractometer, we can measure specific gravity. We use those refractometers in our blood labs. If you remember, we looked at total protein with those. And we used if you took physiology here, we used the refractometer in the urine lab to measure specific gravity. So if we recall, 300 milliosmolar is isosmolar, and that equals a specific gravity of 1.010, the dreaded, or quote-unquote 1010 specific gravity. So if you've got a patient that has a 1010 specific gravity, you're going to need to decide, was it because the kidneys are not functioning, the nephron's not functioning, or is it because they were perhaps dehydrated and became overhydrated and happened to be moving through that 300 milliosmolar or specific gravity of 1010. And so the way to determine that would be to just tell the person, let's not drink water for a couple hours, and let's recollect your sample and see what happens. If we collect it and now your specific gravity is up in the 10-20 range, yeah, okay, your kidneys are working fine, which maybe the osmolarity maybe is 1,000, right? 900, that range. But if we've done a water deprivation test and we're still at 300, well, that tells us there's something going on with the kidneys, with the nephron. The nephron is not working. We're not concentrating our urine. Alright, so here's another slide that kind of shows the numbers from what I was just talking about in the previous slide. And so let's look at what we call the countercurrent exchange mechanism that is used in the loop of Henle and also into the collecting duct. So if we look at, the renal cortex, the osmolarity of that area is approximately 300 milliosmolar, just like we have in our plasma. As we look at the hairpin turn down there and deep into the renal cortex, which would be on the bottom of this diagram, we have an osmolarity, an interstitial concentration outside that nephron of about 1200 milliosmolar. And the way we maintain this is with this countercurrent exchange mechanism. And so the flow of filtrate comes from the glomerulus, goes down the descending loop of Henle, and then back up the ascending loop. On the way down, we're drawing water out, and so if we look at that filtrate, it starts at an isosmolar 300, and by the time it gets to the bottom, we pulled enough water out that we're at 1200 milliosmolar. The countercurrent means that the blood is actually flowing in the opposite direction, so this diagram is a little bit off, and that you should take that blood flow and kind of flip it over, right, so that as the filtrate's flowing down into the hairpin turn, that blood on the vasa recta is actually flowing up against the flow of urine. So again, we have this countercurrent exchange. So when we get to the bottom, we're at 1200 milliosmolar, just like we are with the filtrate, but by the time we get up top, we're at back to a 300 again. So we have a relatively normal blood flow that's coming through. If we go up the ascending loop of Henle, again, that blood is going to be flowing down, right? So we're from a 300 and we get to the point as we're moving up, and we get to the thick ascending loop of Henle, and we have our sodium chloride and actually potassium symporters that's going. So the NKCC symporter. So we're pumping sodium, potassium, and then 2 chlorides out in that area, leaving water. So by the time we get to the end of that loop of Henle, we're at a hyposmotic 100 milliosmolar. And then we go through the distal convoluted tubule, and between secretion and reabsorption, we get back to our 300 milliosmolar or isosmolar portion. But at this point, our volume is much, much less, and we've reabsorbed our important solutes, at least if we're healthy at this point. Another area of control, an important area of control, is the juxtaglomerular apparatus. And so I like the picture of this nephron on the left side because it shows really anatomically more of what happens. And so if we look at that, at the distal convoluted tubule, excuse me, the ascending loop of Henle as it's coming up, it actually kind of splits the afferent and efferent arteriole. So it kind of bends back and round and comes up towards towards Bowman's capsule and the glomerulus there. And so we've got an apparatus sitting there that has 2 different cell types. And so we have the macula densa cells, and we have these granular cells that are kind of monitoring what's happening in that ascending loop of Henle, kind of towards the end of it. So the macula densa actually functions to provide local control. Okay, and so in this area, there's a natural tonic release, and by tonic I mean there's a constant release of nitric oxide. Nitric oxide is a chemical that causes vasodilation, and so if we get vasodilation of the afferent arteriole, the arteriole coming into the glomerulus, that means we increase blood flow, we increase capillary hydrostatic pressure, and we will increase our glomerular filtration rate. So if the macula densa, if it wants to decrease, if we want to decrease in our filtration rate, in other words, things are coming through too fast, we can't get it all back, the osmolarity of that ascending filtrate is actually going up, it sends a signal inhibiting the release of nitric oxide, excuse me, and it constricts that afferent arteriole, thus decreasing blood flow to that area, decreasing hydrostatic pressure, decreasing the glomerular filtration rate. So there's local control based on this macula densa. The other one is important, is the juxtaglomerular cells, the granular cells. These are the cells that secrete renin. Okay, so again, if we get in a fluid overload situation, we want to, if we get a drop in blood pressure, and we have a decrease in fluid, we want to get fluid back. We go to the renin. We start secreting renin, and if you recall, that's the renin converts angiotensinogen to angiotensin 1, which is converted to angiotensin 2, which causes a release of aldosterone and sodium and water reabsorption in the kidney, as well as vasoconstriction in other parts of the body. Alright, so we finished looking, kind of doing our quick review, or sort of quick review of renal physiology. And let's start looking at how we clinically evaluate kidney function. Okay, so what do we look for? What are we going to do if the patient comes in and we're kind of concerned about their kidney function? First thing we do is a urinalysis. We did this in physiology lab if you took that here. And in kidney function, essentially you can do a urine dipstick where we'll be looking for blood cells, looking for glucose, looking for protein, all of which would be considered abnormal. And we can also look at urine concentration. And so we already talked about how you can use a refractometer, as well as sending it off to the lab and actually using an osmometer, which we used in our laboratory here. So we can correlate concentration. So again, our specific gravity in a human urine sample would be somewhere between 1.002 or 1002 and 1.035 or 1035, and our osmolarity will be about between 50 and 1200 milliosmolar of water. Now, just to let you know, it's not really osmolar, and if you read carefully, if you look at textbooks or you look at your lab, it's actually osmolal. And so I'll just kind of identify that you can consider it osmolar. That's really kind of what people talk about, but from a thermodynamic standpoint, what we're really talking about is milliosmoles per kilogram of solution, not liter of solution. And so that's osmolality, which I think you probably learned that in chemistry, not osmolarity. But they're so close in these concentrations that really osmolality and osmolarity can be considered equivalent. So I'm just going to continue to use the term osmolar so we don't confuse you anymore. The other thing we look at is our blood tests. So during a chemistry profile, we'll do there's a couple of things we look for in blood. One is our urea nitrogen, or blood urea nitrogen, BUN. Again, that's a byproduct of protein metabolism, and it's primarily urea essentially is excreted in the urine. That's how we get rid of our nitrogenous waste product. The other nitrogen waste product is creatinine, not creatine, but creatinine. Creatinine is also a nitrogenous byproduct of muscle metabolism, and it is actually the metabolite of creatine, which is used in our short bursts of energy in our muscle contractions. So we'll kind of go more into why creatinine makes a really good blood test or indicator of kidney function in a little bit. So actually in the next slide. The final one is a very important concept called renal plasma clearance. Okay, and so let's kind of define this, and then we'll look at it a little more in depth. Renal plasma clearance is really the volume of blood cleared of a certain substance per unit time. Okay, so we'll be looking clinically. Typically, the substance we use is creatinine. Okay, so we look at how much creatinine is cleared from the blood in a unit of time. If we have a high renal plasma clearance, that means that we've got a very efficient excretion of that product. And so what we really want to look for in the case of a product that we want to use for renal plasma clearance is we want a product that is freely filtered, not reabsorbed, and not secreted. So therefore we can give it a good indication of our glomerular filtration rates in the kidneys. If you have a patient in the hospital and you want to know, it's sometimes very important to know what their glomerular filtration rate. Perhaps you're, dosing a renal toxic drug like an aminoglycoside antibiotic, or maybe you've got kidney disease and you want to know, are we getting better, getting worse, or what's happening? And so the way we do that in medicine is to use a clearance rate of a product, as we just defined. And the two products that we use are either inulin, which would be a drug that we inject into a patient, or more commonly what we use is creatinine clearance. And so to estimate our glomerular filtration, again, we have to have three things true about this product. As I described earlier, it has to be freely filtered, it cannot be secreted, and it cannot be reabsorbed. Okay, so once it leaves the blood, it stays out of the blood, it does not re-enter it, and we do not secrete it from the blood, so we're losing more. So if we do that, now we have a way to estimate our glomerular filtration rate. And so if we call that a clearance. So if we look at the formula up top, really what we need to find a creatinine clearance, and the units of that are milliliters of plasma per minute that we're clearing. We need to know how much urine that patient's producing in a unit time. We have to know the concentration of creatinine in the urine. And then we have to know the concentration of creatinine in the plasma. All right, and those are three things that we can get very easily. For example, we can, to get the urine volume per unit time, we just have the patient void. We then come back an hour or two later, void again, figure out how many mils of urine we voided, and the number of minutes that occurred between those two voids. And voila, you have urine volume per minute. Okay? Then you take that urine sample, now that you have that, you send it off to the lab and say you want a urinary creatinine level. And they'll send you a number back in milligrams per milliliter. The final factor you need to do, we'll need to draw blood on these patients, run a creatinine concentration. Again, that'll come back in milliliters per mil. And so So it's a non-invasive way to really get a very, very close estimate of glomerular filtration rate. And so if we look at the diagram on the right-hand side, it uses inulin. Inulin is a drug that has that exact same property. It's freely filtered, not secreted, nor reabsorbed. And so you can use that as well, but typically we use creatinine in the clinic, so we don't have to administer more drugs to patients. So let's take a look at our afferent arteriole. And so if you look at that little box, number 1, we've got 4 inulin molecules, or 4 creatinine, whichever you want to say. They are now freely filtered. Okay, so now we have actually removed 4 of those molecules out of the tubule, or out of the blood, excuse me, into the capsule. Now we end up going down the proximal tubule. We get to number 3. It is not reabsorbed, okay, and we are not secreting anymore at this point. And so now we have really 100%. All 4 of those are excreted at that point. Okay, and so we can actually figure out if that filtrate containing those 4 molecules is 100 milliliters. Okay, so 100 milliliters per minute. So we've lost 4 molecules in 100 milliliters, and it took a minute to do that. We can calculate our inulin excretion rate to be 100 mils, or I'm sorry, clearance rate to be 100 mils per minute. Okay, and so that's really, again, kind of idealistically how we would do it, or graphically or figuratively how we do it. In the clinics, we would use that formula up on top: urine volume times urine creatinine concentration divided by plasma concentration, and that'll get you a glomerular filtration rate in milliliters per minute. All right, so let's look at a product like glucose that is really normally 100% reabsorbed. Okay, so as long as we don't get too high a concentration, it'll be reabsorbed. And so let's look at the clearance of glucose. How does that affect it? And so the same principles we have. We're filtering 100 milliliters per minute, and in that 100 milliliters, we're going to have 4 molecules of glucose. So glucose enters the proximal convoluted tubule. And all 4 of those molecules are removed, and so really we have 0 glucose that's excreted. Okay? So if we punch those numbers in, the concentration, we can have our urine filtration rate, right, mils per minute. In this case, it's 100 mils per minute, times 0 milligrams of glucose, which is our urine concentration, divided by our blood plasma concentration. When you multiply anything by 0, the answer is 0, and so the clearance rate for glucose is 0. Now I asked the question down below, what about in diabetes? Would it be 0? And so we can actually think about this. In diabetes, you end up spilling sugar into the urine, and so therefore you do have a urinary concentration. And so we'll multiply your your urine rate, excretion rate, production rate, times that number divided by your blood glucose. So yes, the answer is we would have a clearance of sugar, of glucose in this case. And it's primarily because the concentration is so high that we've saturated the channels, those glucose channels, and we cannot get all of that glucose back in by the time it flows through the convoluted tubule. So the final one to look at is, how about a product that's actively secreted and filtered? And the classic is penicillin. And so we'll go through those same. We have a filtration rate of 100 mils per minute. We're going to filter 4 of those penicillin molecules. So down we go. But guess what? In the meantime, we also start filtering more penicillin. And so if we look at by the end, and if I said filter, excuse me, I mean we start secreting penicillin from the blood into the proximal convoluted tubule. Maybe we do it in the distal convoluted tubule as well. And so we secrete 2, then we secrete 2 more, then 2 more, and so in addition to the 4 that we filtered, it looks to me, if I count them up, we've got 1, 2, 3, 4, 5, 6 more. So we've actually got 10 penicillin molecules that we've secreted out, that we've filtered out. And so if we punch those numbers in, our clearance rate of penicillin is actually 150 milliliters. Okay, because now we've actually got a higher concentration in our urine than we would have if it was just freely filtered. So if you look at number 4 down there, Our penicillin clearance is 150 mils per minute. So this shows why, our filtration rate is truly 100 mils per minute. But with penicillin, we have a clearance rate of 150 mils per minute, so it's greater than our glomerular filtration rate. With glucose, we had a clearance of 0, so it's less than the filtration rate. So that just kind of reaffirms the fact that we need those 3 principles to get a glomerular filtration rate estimate. So we need it to be freely filtered, not reabsorbed, and not secreted. All right, time for a little humor pause. I kind of got a kick out of this squirrel cartoon. When I learned you're what you eat, I realized I was nuts. Well, with that, we've kind of finished our physiology. We finished our review of how we actually monitor patients for renal function. So now let's kind of dig into the meat and potatoes of this, which is renal diseases. So in the kidneys, we categorize renal diseases several different ways. One is by the site of the lesion. This is this is a common way to do it. I shouldn't say the most common, because they both are. And sometimes we actually use both of these designations. So again, site of the lesion or nature of the disease. So it could be a glomerular disease, which we would call a glomerulonephropathy. It could be a tubulointerstitial disease. And then sometimes we'll describe why. So for example, you could have an immune-mediated glomerulonephropathy. So we're getting both the nature of the disease and the site of lesion that's going on. Again, we could have a toxic tubulonecrosis, for example, a toxic tubular interstitial disease that's going on. So again, we describe both the nature of the disease and the site of the lesion. So, but at any rate, the result of renal diseases is really going to be hemodynamic abnormalities, because if you recall, the kidney keeps our electrolytes going, it keeps our blood pH going, and it keeps our blood volume going. I shouldn't say going, but under homeostatic conditions. So there's certain areas in the kidney that are very prone to injury, and so these are by far the 2 most common sites of the lesions. One is the renal medulla. The renal medulla has a very low oxygen tension, and if we think about it, primarily because of the high osmolarities that occur in the renal medulla, it's very hard to dissolve oxygen in high salt water concentrations, so therefore we have low oxygen tension. So the renal medulla is very prone to ischemic injury. The other place is the glomerulus, and again, that one is very, very prone to immune complex injuries for reasons we'll describe a little bit later. So describing the kind of the pathophysiology of these, there's really 3 different ways we describe those as well. So we can have damage to kidneys from a pre-renal cause, we can have damage for intrarenal, and we can have damage post-renal, and we'll kind of describe those as we go along. Pre-renal causes, the primary reason is hypoperfusion. Okay, so inadequate blood flow. So we see those as we described earlier in the shock lecture. That's renal disease is a definite sequelae to shock because of hypoperfusion. So we'll see that also with dehydration, hypovolemia. We'll see that in cases of heart failure. All of those will result in decreased renal perfusion, essentially. Intrarenal charges are really direct damage to the nephron and any of the nephron structures. So we could have glomerular disease there. We could have tubular diseases. So again, damage of the nephron itself. And finally, we have post-renal, and those are primarily caused by urinary obstructions, things like stones, tumors, prostatic hyperplasia in men. So again, that builds up pressure, and so we'll describe these as we go along. So regardless of whether it's pre-renal, renal, or post-renal, we kind of have similar manifestations that occur in these patients. Really, the primary thing we see is we get a decrease in the ability to get rid of our nitrogenous waste. So urea, right, our blood urea, nitrogen, creatinine. We actually have ammonia that builds up. We do have some free ammonia that we do is water soluble that we get rid of. The term for this is azotemia. Okay, azotemia. So as we get an increase in concentration of urea and creatinine, which we will find and discover on our blood profile. We'll call those patients azotemic if they've got elevated levels or concentrations of those products. I'm going to kind of skip to the next one, and only because it kind of follows with azotemia. As this continues to get worse and worse, in other words, these concentrations of urea, ammonia, and creatinine are elevated higher and higher, we get to a point where we call this uremia. And that literally means urine in the blood. So we're really not excreting anything at all, or very little, I should say. This is a very, very severe condition, very toxic condition for the patients. And fortunately, we have a lot of reserves, and we're pretty resilient with renal damage. And we need to be to a point where we're over two-thirds of the nephrons in both of our kidneys need to be damaged before we get to that uremic condition. All right, I'm going to skip back up to the second one. Again, we'll see imbalances with sodium, potassium. Our pH balance will go out, and again, our water balance will be affected in renal diseases. All right, so here are the renal diseases that we're going to look at. We'll look at obstructive renal diseases. We'll look at our glomerulonephritis, which kind of the end stage of that is nephrotic syndrome. And then we'll kind of look at acute renal failure and chronic renal failure. And I'm going to kind of give you a warning. These things, when you get to the acute and chronic stages, they can be from the previous one. So it's going to kind of blend in together a little bit. It's much like we dealt with our cardiovascular unit and our heart unit, where we get into the causes of cardiomyopathies, and then we actually looked at a heart failure, right? A heart failure in the end. So obstructive renal disorders are actually pretty simple, pretty basic if we think about it. It's really anything that's going to block or obstruct the flow of urine in the filtrate. Okay. One of the most common causes are renal stones. They're called calculi. Okay, so renal calculi, and they can be made up of several different things. We'll discuss in a little bit the constituencies of renal calculi. Some of the risk factors that we see for getting kidney stones is dehydration, particularly chronic dehydration. One of the reasons why people really promote staying hydrated and drinking water frequently. We also see it in our Western diets, our high-protein diets, primarily because of changes in pH. We have a more acidic urine the more meat that we eat. Vegetarians typically have a higher or more alkaline urine, so these stones are more soluble in alkaline than acidic urine. And also high sodium diets, because that actually increases our calcium excretion. We have to exchange sodium for calcium. And so now we end up getting some calcium salts that precipitate out into our urinary tract. So in our kidneys, I guess, what we're dealing with here. So we can also see it with developmental defects. Again, I mentioned prostatic hyperplasia in men. Tumors anywhere downstream from the kidney itself can cause that. And pregnancy. So the gravid uterus, in other words, the fetus itself is putting pressure on the ureters and bladder, causing pressure to build up into the kidney itself.
The consequences of obstructive renal failure can actually be fairly severe. So if we look at one of the outcomes of the obstruction would really be a lack of flow of the urine or stasis of the urine. And if you remember your immunology, the flow of urine is actually a physical barrier for bacteria from ascending up the urethra into the bladder and up the ureter into the kidney. And so as urine flow slows down, these patients are predisposed to infections and stone formation. Oftentimes these two go hand in hand. The bacteria that infect the bladder and kidney oftentimes are urea splitting bacteria. The most common ones are things like Proteus, Staphylococcus. Actually, E. coli is the most common bacteria that ascends and infects. And then the stones, because of the stasis, the stone is forming, and the bacteria the stone kind of forms a nidus, or a storage depot for that bacteria, and then it becomes very, very difficult to treat because you put a patient on antibiotic therapy, and they seem like they're doing better, but you take them off, and all of a sudden the bacteria that were in that stone were protected from the antibiotics. And so the vicious cycle, it becomes a chronic infection, basically. The other thing that happens is as the pressure builds up, it's going to start dilating the renal pelvis and calyx, and that pressure is going to cause kind of a pressure atrophy, which leads to the next step, which is hydronephrosis. And what happens in the kidney is we're obstructing it downstream, and either in the renal pelvis or the ureter or the tubule somewhere, and the kidney continues to filter in the glomerulus. And so basically what's happening at that point is we're building pressure because we're adding fluid to the tubule and the system, yet it doesn't move out very fast. And so that pressure, again, is going to further dilate the renal pelvis and calyx. And that pressure is going to cause ischemia and damage the kidney architecture. And in fact, that pressure leads to intra-abdominal hypertension, which can result in what we call an abdominal compartment syndrome. And when we think of compartment syndrome, we haven't really covered that in this class, but compartment syndrome is really just when we have compromise of blood flow to tissue. Very commonly we'll see that in the appendages, where we get a vasospasm, decreased blood flow, and then you run the risk of killing off your limb. And in this case, we have the same thing that happens, but it happens in the abdominal cavity. So our viscera, our visceral organs, in other words, start shutting down. So things like the GI tract, the liver, and in fact, it even may back up into cardiovascular and pulmonary systems because of that hypertension that's occurring in the abdominal cavity. And this leads to renal ischemia, which again causes cell death and necrosis and atrophy in the kidney.
So why is this pressure bad? Well, it's bad because it makes kidneys look like this. This is hydronephrosis, and so if you look at the kidney, you've really got a relatively normal renal cortex. At least initially, you do. If we look on the left-hand side, you can see that. But we've really, at this point, lost a lot of our renal pyramids. So we've lost a lot of the nephrons that we have in this. And so this is all due to pressure necrosis. Okay? So pressure's built up. Our heart continues to pump. Blood continues to go into the glomerulus. We continue to filter. So we continue to produce urine. And that urine continue to produce filtrate, and we continue to produce urine. And so that builds up pressure. And again, if you remember, the renal medulla is very prone to ischemic injury. And with that pressure, now our blood flow decreases, and so we have ischemic necrosis. And it leads to this condition where we've got these blown up renal medullas, or renal pelvises actually. And if you also look, we've lost our architecture. We've replaced our nephrons with scar tissue. And so at this point, that kidney really isn't doing much for us at all. So back to our stones. Again, this is the most common reason, at least most prevalent reason for obstructive renal diseases. There's several different types. Let me kind of go down to the bottom first. There's really 4 types of kidney stones that we see. One are calcium stones, so we can have calcium oxalate or calcium phosphates. The other one is magnesium ammonium phosphate stones. Those are also known as struvite, S-T-R-U-V-I-T-E stones. So struvite stones, again, are a magnesium ammonium phosphate stone that occur. We can have uric acid stones, particularly in people that are prone to gout. And then finally, there's an amino acid stone called cysteine stones. Okay? And so we'll see any one of those 4 for multiple different reasons can result in this kidney stone. The theories are really the way that these stones are formed. We don't really have a fixed handle on this for sure. That's why I continue to call them theory. I think it's probably a mixture of all of these things, and in fact it probably is. One is the saturation theory. So if we get excess, much like you saw in chemistry, if you get excess solute concentration of these things like calcium, magnesium, ammonium, those kind of things, uric acid, you're going to reach saturation, you're going to start precipitating. The other theory, or probably the other thing included in that saturation pore, is there's probably some organic material that acts as a starter for that stone, kind of the nidus for the stone formation. So this would be very similar to taking a sugar solution, heating it up, supersaturating that solution, taking a crystal of sugar, dropping it in that beaker, and it'll start precipitating all of that sugar at that point. So it's probably the same way with our urinary stones. The final theory is really the inhibitor theory, that there's some substance in our kidneys that really inhibits stone formation, and there's a deficiency of that. So I think the first two theories are probably a little bit more significant when it comes to the formation of renal calculi than the third one is. All right, stay away from that lemonade stand. It does not taste very good. All right, moving on from our obstructive disorders, let's look at our intrarenal disorders, and let's start with the glomerulus. So the glomerulus is a very common site of damage in kidneys, and we'll kind of look at the different methods that happen. So the three categories of glomerular damage that we see are proliferative, sclerotic, and membranous. Okay? In proliferative glomerulopathies, we actually see an increase in number of cells in that area. In the sclerotic form, we actually see an increase in our collagen formation around that area. So we get that sclerosing, really scar kind of formation around the glomerulus itself. And then finally, our membranous, we really get a thickness in the capillary wall of the basement membrane. We get an increase in the thickness in the capillary wall of the basement membrane. So if we remember from our simple diffusion talking, if we get a thickness in the membrane, we have more difficulty diffusing things. So all of these can really decrease our filtration rates, okay, the efficiency that we filter by. I think membranous nephropathy is really the most common cause of what we call idiopathic nephrotic syndrome. And we'll talk about nephrotic syndrome in a little while. It's a kind of an end-stage kidney disease that we have. Some other causes that we see of membranous nephropathy are infections, autoimmune is very common, and then finally malignancies can cause these glomerular damages. So when the damage gets bad enough, it really, at this point, now we start becoming very, very leaky. And so initially we may start decreasing our filtration rate, but then pretty soon we blow up, and now we're letting things like proteins, things like blood cells, those kind of things that normally don't go into the urine, that are normally not filtered, become filtered. And so now we start seeing hematuria, which means blood in the urine, proteinuria, which means protein in the urine. Again, we continue with our GFR is still down. We can't get as much fluid through these areas, and these patients become hypertensive because of this fluid overload that they have. So to understand glomerular disease, we really kind of have to look more at the architecture of an anatomy, I should say, of the glomerulus. And so here's a figure from your textbook of a normal glomerulus and kind of all the constituents that go into that. And so we've just got kind of a cross section that we've taken. And so if we look out, we've got the capillaries. If you look, I've got in red, it's circled fenestrated endothelium. So that would be the capillary endothelium. It's about the size of one red blood cell, and it's fenestrated. So these are the leakiest capillaries in our body. Okay, so they've got these holes in these fenestrations in the endothelium. And if we look on the left-hand side, I've got circled the basement membrane. Okay, so we've got the basement membrane surrounding that blood vessel, the endothelium. So we have to filter through the fenestrations, through the basement membrane, and then finally we have these podocytes, okay, which is our visceral endothelium. Okay, so those are kind of holding. That's kind of the framework. Those are the structures that hold these things kind of apart, these tufts of capillaries apart, and they've got these little foot processes that surround the capillary and support them. So if we look at on the right-hand side, this is actually a membranous nephropathy, figure 2711 out of your textbook. And so now our podocytes are kind of effaced. They've kind of surrounded an area. There's a thickened basement membrane. Okay, and so now we've got this sclerotic area that is in there. And so if we look at the histopathology up on top, we don't have those nice little capillaries. We have these big thickened membranes that consist of the podocytes and basement membrane, so now we're going to be backing up. Our hydrostatic pressure is going to be getting greater. We have a harder time pumping blood through those areas, and these are leakier cells. So we get this diffuse thickening of the basement membrane. We also oftentimes have immune components to this. So we'll have immune deposits that occur of immunoglobulin, IgG typically, and then we start having complement activation, and these membrane attack complexes start attacking the membrane thickness. And so between those, that's essentially the process by which we see this thickened membrane and the foot processes on the effaced foot processes on the podocytes. In cases of inflammation of the glomerulus, we call that glomerulonephritis. Okay? And so really it's any inflammatory, anything that triggers inflammation in the glomerulus, although we'll talk about a few things that are more common than others. So we really have three forms that we see. One is the acute or rapid onset form. The other is a rapidly progressive form. And the third is a chronic form. Okay? And so one can lead to the other sometimes, so depending on what it is. So in the acute form, typically the most common reason we see acute glomerulonephritis is following an infection with a beta hemolytic streptococci bacteria. And so the antibodies that our body produces cross-react, well, that should react to the bacteria, but they also cross-react with the host antigen, which are found in the glomerulus. And so now these immune complexes attach to the glomerular capillaries. Again, we get through that process, we activate complement, we get the membrane attack complex going, and we get an acute glomerulonephritis that occurs. Usually we can, if we get it early enough, we can treat this with antibiotics. If we can get rid of the beta hemolytic strep, then in time the renal portion of that resolves as well. With rapidly progressive, this one is a little bit slower. It's over several months. It typically starts with an acute form, and if it keeps going and doesn't stop, it ends as chronic. Okay. The most common reason we see for this are autoimmune disorders, and so just like we had with the beta hemolytic strep, we have immune complexes that attach to the basement membrane and cause an immune attack to that area, or an inflammatory response, I should say, to that area. Some of the diseases that we see this with are systemic lupus erythematosus, which is SLE, and Goodpasture syndrome is another one that we'll see a rapidly progressive glomerulonephritis occur. As this continues on over time, we get to the chronic portion, where really we have obliteration of a vast majority of glomeruli, and then the sequelae will be chronic renal failure, which we'll talk about a little bit later. So in these patients, we'll see hematuria, proteinuria, we may see oliguria, where we have an increase in urine formation. These patients will be azotemic to uremic, depending on what phase they're in. We'll see edema in the patients due to low protein in the blood, and they will be hypertensive. So here are a couple of examples of the immune mechanism, a couple different pathways, I should say, to glomerulonephritis. One is a type 2 hypersensitivity, which essentially now we have this antibody, right, that is reacting to the antigens in the basement membrane. So this perhaps would be our streptococcus antibody reacting to the antigens that we find in the basement membrane. With our type 3 hypersensitivity, these are going to be circulating antigen-antibody complexes and they're going to lodge in the fenestra and the basement membrane, and maybe sputum will leak into the podocyte area again. So now we have those immune complexes, both of which are going to be activating the inflammatory response, activating complement, and causing damage in the area. Nephrotic syndrome is a sequelae to glomerular disease. Okay, so it's a syndrome. So it doesn't really matter what leads up to this, right? It doesn't matter. It could be glomerulonephritis. It could be, we could have immune-mediated things. But whatever, there's a glomerulonephropathy. Something is going wrong in the glomerulus. And as it goes on to our chronic stage and we get to the end, it's very common to see this thing that we call nephrotic syndrome. The hallmark to nephrotic syndrome is the loss of plasma proteins into the urine. Okay, so put that down. When you think of nephrotic syndrome, think plasma proteins leaving the blood going into the urine, and that'll kind of tell you exactly what's happening, and you'll be able to predict all of the signs and symptoms that you're going to see primarily with this disease. So at least most of them. So right away it starts. So if we look at this diagram on the right-hand side, it came from a different textbook, but I thought it was just kind of pertinent to this. So we'll have glomerular damage for any reason. We'll get an increase in permeability to that area, so we get a massive proteinuria. In this case, they define that, well, in all cases, we define it as greater than 3.5 grams per day of plasma proteins being lost. That's going to lead to a hypoproteinemia. Okay, so I've got on the other side hypoalbuminemia, which is really the primary blood protein, but it's we'll be losing antibodies, we'll be losing clotting factors, all those kind of things as well. And so now we've actually decreased our oncotic pressure, right? Our colloid plasma osmotic pressure, and so we now start seeing edema, right? So we can see generalized edema. We can see so we can see dependent edema. We can see ascites, and we can see pulmonary edema. Okay. The other thing we're going to do is start having salt and water retention, because now we've decreased our oncotic pressure. We want to kind of get that back, and so we'll increase our plasma proteins. The other thing we'll see is now, since plasma proteins are made in the liver, they're going to start compensating by just starting to make all the proteins that they can, including our lipids, right? So we start making protein, and that's going to lead to a hyperlipidemia, and so we actually are going to start losing lipid in the urine as well. So we'll see massive lipiduria with this also. So the consequences, we can kind of predict these, but some of these just kind of, you can predict them, they make sense once you look at them, but some of the consequences that we have is, number one, an increased susceptibility to infection, and primarily because of a decrease in our immunoglobulin. IgG happens to be the most pertinent with that, one of the highest concentration in the blood. So we'll be losing our antibodies into the blood, so now we're more susceptible to infections. The other one is hypercoagulability. Now that might be not so intuitive. So we're thinking, well, if we're losing clotting factors, we should not clot, right? But really what we're doing is we initially lose more antithrombin 3. And if you remember, antithrombin 3 is what inhibits clot formation. And so when we lose our antithrombin 3, even though we are losing clotting factors as well, the clotting inhibition is decreased. And so now we start seeing patients that clot. So I hope that kind of works out in your mind, but it's kind of the opposite of what you would think. We also have a vitamin D deficiency, and so we're going to have some well, these last two are actually endocrine disorders that are secondary to nephrotic syndrome. Since we lose the vitamin D binding protein, so remember vitamin D is actually a fat-soluble vitamin, so we have to have it on a protein to move it around. With loss of that, we lose our vitamin D concentration, and we end up getting what's called secondary hyperparathyroidism. So our calcium concentrations drop, and now our parathyroid gland is trying to compensate for that by putting out parathyroid hormone. So, and finally, we have altered thyroid function tests. There's really nothing that went wrong with the thyroid gland. The problem is our thyroid hormones are also fat-soluble hormones, and they are bound and transported in our thyroid binding globulin. Because we lose that, now we have a higher free concentration of thyroid hormone, and just like with drugs, free hormone are the active forms, and therefore these patients actually may become hyperthyroid in the nephrotic syndrome situation. We will end our renal lecture here finishing, I should say, with acute renal failure and chronic renal failure. Just as a reminder, these are actually not necessarily due to one cause. It could be due to any cause. In fact, it's anything that damages a kidney. And so if we look at the definition of acute renal failure, and by the way, this is we're starting chapter 28 now in Copstead. So, but it's a group of disorders. So it's a group of disorders that has rapid deterioration or rapid loss of kidney function, which is going to result in the accumulation of the nitrogenous waste products that we discussed earlier, blood urea, nitrogen, ammonia, and creatinine. Just as a reminder, we have different really etiologies of acute renal failure. We have the pre-renal renal failure, which is really a decrease in blood supply. This is the most common form. We have our kidney damage itself, the intrinsic form of renal failure, and that's when we have, primarily for acute renal failure, we're dealing with the kidney tubule function decrease. So we can have ischemia to the adrenal medulla, toxins again, we can have obstructions of the tubules themselves rather than downstream function. So here we're looking at damage to the nephron of some sort. And then finally our post-renal effects, where we block urine outflow, so we continue to have glomerular filtration. However, it's obstructed, so now we have a kind of a damming situation where it's blocked downstream and pressure builds up upstream, leading to pressure necrosis. So to differentiate between pre-renal failure and intrarenal failure, or internal kidney damage, there's several lab tests that we can look at. Some require blood, some require urine. Actually, to get the whole panel, you need a sample of both a blood sample and a urine sample. So let's kind of maybe just look down at the values that we'll look at and how we differentiate pre-renal from intrarenal disease. So the first one, very top one, FeNA, actually stands for the fraction of excreted sodium, and it's a percentage that we get. And again, we would need blood concentration as well as urine concentration and time, because really what this is looking at the clearance of sodium from the blood. So again, this is a renal clearance test that we're looking at. And so if we have a pre-renal failure, that means that we have decrease in renal perfusion. That is actually going to generate renin secretion, right? So that'll stimulate, I should say, renin secretion. So now we get the renin-angiotensin system kicked in. And so what happens at that point is aldosterone will be secreted by the adrenal glands, and aldosterone is going to increase the percentage of sodium that's reabsorbed into the blood. So renal clearance of sodium would go down, okay? Because now we're reabsorbing sodium back into the blood, so it's filtered and then reabsorbed at that point. So that would be a pre-renal failure. In intrarenal failure, so now we have either tubular damage, so those sodium pumps don't work anymore, so now we're losing more sodium, so our sodium clearance increases, thus we have a higher percentage of sodium clearance, or sodium excretion, I should say. Or we could have damaged glomeruli, and that damaged glomeruli is going to decrease our GFR, our glomerular filtration rate. That's going to lead to a hypervolemia, so now we get an increase in blood volume, which will result in a decrease in our renin-angiotensin system, less aldosterone. Now we have a greater excretion of sodium into the urine. So FeNA is a very useful finding. And again, we can just think of it as sodium excretion, and again, it should make sense if one understands the body's response to these changes, at least the kidney's response, I should say, to changes in blood flow and blood pressure in the kidney itself. With another thing we'll look at is protein in the urine, or proteinuria, with pre-renal findings. Obviously, the glomerulus is intact, so we don't have any filtration of the protein. If we have a glomerular disease, obviously we can have proteinuria in that, so it's possible to find that in intrarenal. With urine-specific gravity, again, the kidneys think that we are dehydrated essentially because our blood pressures drop down, so we'll have a very concentrated urine. With intrarenal findings, we could be anywhere from 10-10, right, which is really isosmotic to the plasma, so we are neither diluting nor concentrating urine, or possibly up to maybe 10-20. So we'll have an inhibition of the, or I should say, an inadequate concentrating ability of the kidneys. Another one we'll look at, actually it pertains again to urine osmolality, and as I described earlier, really, we think of it as urine osmolarity, the difference being it's the number of milliosmoles per kilogram of solution instead of liter of solution. And if that's greater than 500, again, we're concentrating the urine. If it's 300, that'd be isoosmolar to, actually isoosmolal, if we want to use that term, but again, the numbers are going to be very, very close to plasma, so that ties into our specific gravity as well. We're neither concentrating nor diluting urine. So 10-10, 300, those are isosmotic and same specific gravity. So we'll also look at the blood urea nitrogen to creatinine ratio. In cases of pre-renal failure, again, we'll have a greater than 20-to-1 ratio of BUN. With intrarenal failure, it'll be 10 to 20 to 1, and so we can use that to indicate whether it's pre-renal or intrarenal. We talked about urine sodium concentration. This one is actually in millimoles per liter. Again, it comes up to the FeNA percentages up top. So the less sodium we have, really, in the urine itself, the more aldosterone that's being secreted. And the greater the concentration, that means that we're actually clearing sodium quicker, we're losing sodium. So we can use our urine osmolarity of sodium to determine those as well. And then finally, urine sediment. We'll talk about urinary casts actually in the next slide. And so we'll see few casts. Again, the kidneys are healthy, so we won't see casts in the urine sediment. Where if we have tubular necrosis, we'll see tubular casts. If we have glomerular disease, we can have cells, red cells, white cells, and even cellular casts in the urinalysis. So in acute renal failure, really the hallmark to acute renal failure is what we call acute tubular necrosis. So let's kind of describe what's going on. If we look at the diagram on the right-hand side, we could either have a glomerular disease, which is causing problems with filtration, or we could have acute tubular necrosis due to toxins or lack of blood flow, right? So we have ischemic or toxic insults, but at any rate, somehow we're having ischemia and damage to the lining of the nephrons. So when that happens, these cells undergo ischemic necrosis. Okay, so they start dying off. When they die off, they become loose from their basement membranes, and they float into the lumen. Now, when this happens in massive quantities, we have kind of an obstruction or a damming that occurs of all those dead cells. And so if you notice on the bottom of that diagram, we have, it says an obstruction. That's an obstruction of cells. Now again, it could be an obstruction of cells because of white blood cells, red cells coming through the glomerulus, or it could be, and typically is, the epithelial cells that line the nephron, the lumen of the nephron. So when that happens, we continue to filter in our glomerulus, and so now we get pressure built up again, which is going to cause some leakage into the interstitial fluid. It's also going to cause an increase in pressure in that, which is going to make the tubular necrosis even worse. And some of those are actually going to kind of blow loose, much like a bullet out of a barrel, right? So it's going to make its way through the nephron, and so when you do your your urinalysis, you'll spin that urine down. You'll look at the sediment, so our urine sediment. Put it on a slide, stain it, and there's a picture down below of a tubular cast. Okay, so those are actually necrotic tubular cells that have actually blown loose out of that nephron and have made its way down to the bladder. So depending on how severe it is, this is a reversible process if we can reverse that injury. But if we continue on, obviously it will become irreversible, and that tissue will be replaced with scar tissue. Alright, so fun diagrams out kind of the pathophysiology of acute renal failure, specifically acute tubular necrosis. Here again we have really the inciting cause is ischemia, which could be due to low blood flow in the area, or could be a nephrotoxin, right? Like as we discussed earlier, gentamicin, which is an aminoglycoside, or aminoglycoside antibiotics, or some other nephrotoxin. At any rate, we have an acute tubular injury in that area, which also brings upon inflammation. Okay, so we have that inflammatory response. We have injured epithelial cells lining that tubule. That brings in inflammatory cells. We start sloughing our tubule cells, and so we get this cast formation, right? And so those they obstruct the tubule itself. And there's a picture, if we look on the right-hand side there's another picture of a cellular cast. Now these are degenerate cells, and this particular picture is not stained, so we don't really have a lot of differentiation on that. We don't have any stain or coloration, I should say. But these are really necrotic cells, and I just by looking at them, I can't tell whether they're tubular cells or whether they're inflammatory cells. They're probably a combination of the two, to be honest with you. But at any rate, now we have that cast that's obstructing the tubule. That increases our tubular pressure. Now we get that increased pressure, slows down our glomerular filtration rate. We get tubular back leak, which continues to, again, build up pressure in that area. It decreases our glomerular filtration rate, which leads to oliguria. Okay, which is a decrease in urine production, a remarkable decrease in urine production. So again, the hallmark of acute renal failure, acute tubular necrosis, is oliguria. So that'd be the clinical sign that we're looking for. All right, so clinically, that's what's going on in the kidney, right? What we just described with acute tubular necrosis, cast formation, decrease in GFR, and eventually oliguria. So let's look at the progress of this particular disease, acute renal failure, as it makes it through actually it progresses through its phases in the patient itself. So we divide acute renal failure into 3 different stages, and so really again it all starts with the early stage of acute tubular necrosis, cast formation, decrease in GFR, and so when we get to that, it really takes hours to days. We reach what's called the oliguric stage. Okay, and so this is where we have very little urine output. So if you've got a patient that has that, you want to start increasing blood flow, particularly if it's a pre-renal cause of acute renal failure. And again, remember the drug of choice in that case is dopamine, because we've got dopamine receptors in the renal vasculature, which leads to vasodilation. So in the oliguric stage, what we're going to see is a marked decrease in GFR. We'll start seeing our blood urea nitrogen and creatinine, so our nitrogenous waste products will start coming up, our concentration in the blood. We'll start retaining potassium, so we'll see hyperkalemia, which if that becomes severe enough, obviously can lead to issues with our heart and the electrical physiology of the heart. We'll see an increase in sulfate also coming up, and so as that progresses on, we'll go from azotemia to uremia if it's very severe, and we may actually get into that uremic syndrome where again we have very, very high concentrations of ammonia, creatinine, and blood urea nitrogen in our blood. So as you progress through the oliguric stage, now we have what was called the diuretic stage. Okay? And so this is actually usually after a few days of oliguria in acute renal failure. At this point, our urine volume really increases remarkably, okay, but our tubule function doesn't work at all, and so now we get into phases where we're urinating, producing a lot of urine, and so that leads to hypovolemia. It leads to hypokalemia. So now instead of having high potassium concentrations, we start losing it into the urine and we have low. Yet we remain azotemic and uremic, okay? And so we maintain that high BUN, creatinine, and ammonia concentration in our blood during this stage. If you make it past that diuretic stage, if we can keep you alive long enough, then the patient reaches, well, I should back up. The diuretic stage, really what happens at this point is the patency of the nephron comes back. So in other words, perhaps we've sloughed off as many cells as we can. We've decreased the number of casts that are there, so we have had a massive flushing of those casts into the urinary system. And so now the tubules are patent again, and so we're producing lots and lots of urine, but unable to really pull the fluid back into our bloodstream, so we have problems with resorption. All right, so back to the recovery stage. Again, our kidneys can repair themselves if it hasn't been going on too long. We haven't had damage and scar formation in there. And so eventually you'll have gradual return to urine output. We'll typically continue to have diuresis until we can replace those cells. And often we'll have a degree of renal insufficiency, so not all of those nephrons will recover. Many of those will be replaced with fibrous tissue or scar tissue. So it's fortunate that we have actually some excess capacity in our kidneys. Alright, so that was acute renal failure. Now in chronic renal failure, this is really something that comes on much slower over a period of time. So it's really what we consider a progressive disease, and because it's progressing slowly, the nephrons are actually being replaced by scar tissue slowly as well, and so it's an irreversible destruction of our nephrons, our kidney structure. The hallmarks of these are going to be reduced glomerular filtration rate. We'll see problems with tubular resorption, and then we're going to have issues with the endocrine function of the kidneys. So we'll specifically see one of the more important ones is with our blood hormone, erythropoietin, so as well as others like vitamin D and those kind of things. So the etiology of chronic renal failure, diabetes is by far the most common cause. The second is hypertension, and the third most common cause of chronic renal failure is glomerulonephritis. So development of chronic renal failure, again, goes in several stages. And again, this may take a long time, over months to even years, depending on the etiology and the progression, the speed of progression of kidney damage. But the first stage we'll see is just really a diminishing renal reserve. As I talked about earlier, we have excess capacity. In fact, we can give a kidney as a donor to one of our relatives or friends or even somebody we don't know, and do just fine. And so you really need to see a reduction in GFR greater than 50% before we start seeing clinical issues or something that we can pick up on lab tests. And so in this diminished renal reserve phase, phase 1, or stage, I should say, stage 1, we see a drop in GFR, yet our BUN and creatinine, so our nitrogenous waste products, are normal. So our blood concentrations are normal. So we really haven't really affected anything at this point. Once we get to seeing a GFR less than 50% of normal, so 20 to 50% of normal, now we start having some problems. Okay, and so one of the issues is we have what's called isostenuria, and isostenuria is when our urine-specific gravity is the same as our plasma. So if you remember, its specific gravity is 1010, 1.010 in plasma, and when our urine is 1010. It means we're really not concentrating nor diluting that urine at all. So it would have an osmolality of around 300 milliosmol. And so again, that's at this point now we have renal insufficiency, and then we reach into the stage once we get below 20% of normal glomerular filtration rate. And I should kind of back up. I guess the hallmark of chronic renal failure is a diminishment in glomerular filtration rate. So acute renal failure was acute tubular necrosis. Chronic renal failure is a drop in GFR and really below 25%. So once we get to this point, we'll have, well, I should back up, in renal insufficiency we'll have some azotemia, so our BUN creatinine will be rising. Once we get to chronic renal failure, now we are uremic. We've lost the ability to really get rid of our nitrogenous waste products altogether. And once you get to the point where you are less than 5% of a normal GFR, you're in end-stage renal disease. So patients in 3 and 4, stage 3 and 4, are typically the patients that we bring into dialysis and try to get rid of those waste products for them. Alright, so here's a table out of your textbook looking at how we determine this clinically, and so we actually have numbers that we can use to identify which stage of chronic renal disease or kidney disease we are, and it's based upon our glomerular filtration rate. And so just as a quick review, remember we have a nice little way to measure GFR, and if you remember, we can use our creatinine clearance, right? So our creatinine clearance, so all we need to do is know urine volume per unit time, creatinine concentration in the urine, creatinine concentration in the blood, and we can calculate out our creatinine clearance, which is going to be equal to our glomerular filtration rate. And so in stage 1 we'll see a GFR of less than 90, and again that'd be 90 mils per minute for a standard body size, which we actually use our body surface area, 1.73 meters squared. And so stage 2 would be between 60 and 89, stage 3 would be between 30 and 59, stage 4 we're at 15 to 29, and then at end stage we're really at less than 15 mils per minute per our body surface, standard body surface area. And those patients really at that point are usually having dialysis, and so it may be actually hard to determine GFR because we're removing that for them. So there's some real standard clinical manifestations that we typically see in these patients, and oftentimes these patients are on a lot of drugs trying to counteract these manifestations. So typically they'll have a fluid overload and a sodium overload. Okay, so our sodium balance and our volume status is off, and so we will have an increase in body water. We'll typically see a hyperkalemia, and this is actually so we'll have an increase in potassium. It's aldosterone mediated because to reabsorb sodium, which is what we'll be doing, we're actually going to be exchanging that for potassium. And since we're not doing that, since we're not really having the renin-angiotensin system working like it should, we have less aldosterone being released. We have less sodium and potassium being exchanged, so we have more potassium actually staying in being reabsorbed into the bloodstream, and so we have a hyperkalemia. So electrolyte imbalances, hypernatremia, high sodium, hyperkalemia, high potassium. So that's kind of the hallmark of CRF. We see a metabolic acidosis. Okay, so the patients typically will try to compensate that with their respiratory system. So there will be increasing breathing, trying to get rid of bicarb. But in this case, the acidosis is due to the decrease in GFR, and we'll see that when we get less than 20 to 30 mils per minute, we'll have an acidosis. We'll also have some mineral and bone issues. So we have a calcium phosphate imbalance. Typically we see a decrease in calcium absorption because vitamin D is required for that, and we need to activate vitamin D in the kidneys. This is going to lead to an increase in parathyroid hormone, trying to get calcium concentrations up, which is the function of that hormone. That hormone actually acts on the bones and releases calcium from the bones as well as phosphate. So, and again, we end up with a chronic metabolic acidosis, which causes the bones to dissolve easier. So, continuing on with the manifestations, our cardiovascular and pulmonary manifestations are typically hypertension, again due to the volume overload of those patients. So it's very common to put extra work on their heart, and the sequelae to CRF is congestive heart failure and pulmonary edema. Again, due to that volume overload, we're working the heart too hard, and we will end up pooling fluid into our lungs. We can also see from the uremia, the nitrogenous waste products are are very toxic to or I should say irritating to the pericardium. And so we'll get a pericarditis causing a pleural effusion. I'm not pleural effusion, I'm sorry, pericardial effusion, and increase and really cardiac tamponade, right, is what we will end up with in the end stage of that. These patients will very commonly be anemic. In fact, erythropoietin epigen is the drug that was cleared originally in medicine to counteract the anemia found in chronic renal failure. And so epigen or erythropoietin is used to treat these patients to get the red blood cell count back up. And others we see there's GI effects, there's other endocrine effects, there's central the uremia causes central nervous system effects, we see skin changes. So these patients really have effects in virtually all organ systems due to this uremia and which is high nitrogen concentrations in the blood. All right, so to summarize the clinical presentation of chronic renal failure, I added this diagram, which actually it comes from a different textbook, but I just, if you kind of know this diagram, you'll understand if chronic renal failure very well. So let's kind of start on the left, kind of highlight the clinical signs that we have. So again, number one, we have sodium and water imbalance. We get an hypernatremia, too much sodium in the blood, and a water retention. So we end up having a volume overload. That is going to, both of those will lead to hypertension, increasing the work on our heart, as well as edema. Okay, so we both have ascites, dependent edema, pulmonary edema. Any of those are possible in these patients. So moving to the right, we have potassium imbalances. So we have a hyperkalemia, another hallmark of chronic renal failure. So we will have things like skeletal muscle issues, heart muscle issues because of that elevated potassium in the blood. Another hallmark is our azotemia and uremia, actually once you get to CRF stages. So we have trouble eliminating our nitrogenous waste products, and that leads to a plethora of issues in our body. One kind of moving down is it has issues with our clotting system. It actually activates the clotting system, so we have coagulopathies that go on. I'm sorry, not activated, it inhibits the clotting system, and so we have trouble clotting, so we'll have bleeding issues. We'll have irritation to the pericardial sac, so we get a pericarditis leading to a pericardial effusion, resulting in cardiac tamponade, again exacerbating the heart failure that we have from the volume overload. It affects the immune system, it affects skin, the gastrointestinal tract, our nervous system, and even reproductive systems. So by really the broadest reaching one of all of these is the increase in nitrogenous waste products in our bloodstream. One of the endocrine problems is decrease in erythropoietin production from the kidneys. So we have less stimulus to produce red blood cells in our bone marrow, resulting in anemia. We have acid-base imbalances. We get an acidosis in these patients, which has several problems. One is skeletal buffering. Okay, so now because of the acidity in our blood, we tend to dissolve our bones. So we end up having kind of softer bones or osteodystrophies because of that. Compounding that osteodystrophy is we have trouble activating our vitamin D. And vitamin D's function in the body is to increase blood calcium by increasing absorption of calcium from our diet. So that leads to a hypocalcemia. So now our softer bones that we have are having trouble making themselves again because we have low blood calcium. And the last thing that we see is a problem with phosphate elimination. So we have a hyperphosphatemia, again another hallmark of chronic renal failure. Because phosphate and calcium kind of go hand in hand. With that elevated phosphate, now we have less impetus to dissolve calcium from the bones, and so that exacerbates the hypocalcemia that we get from the inactivated vitamin D issue. And that hypocalcemia and hyperphosphatemia actually leads to what we call hyperparathyroidism. The parathyroid gland is trying to increase blood calcium because of the hypocalcemia that we're having. And so it's really trying to make up for the vitamin D, lack of vitamin D. And the way that actually works is to activate the osteoclasts in the bone, thus dissolving more bone, again exacerbating the osteodystrophy that we're having. So there's really a three-pronged approach to our bone and mineral disruption that we have in chronic renal failure. So that concludes our renal disease unit. We'll cover this in class. I'll answer any questions in our next class meeting, and so kind of come prepared in class, because I'm sure you have some questions. You should. If you don't have questions, I'd like you to go through the presentation again and the book again, and kind of come prepared with questions so we can kind of clear up anything that is not understood from this PowerPoint.